My name is Antonio Pelliccia. I'm one of the co-chair of this document, together with Professor Sanjay Sharma from London. Personally, I'm a senior cardiologist, former chief of the Institute of Sports Medicine and Science of the Italian National Olympic Committee in Rome, Italy. And as my background, I am a cardiologist and specialist in sports medicine. And my primary interest is the knowledge in pathophysiology of cardiovascular system with regard to exercise and sports participation. We have to specify that these are the first official guidelines of the European Society of Cardiology, but not the first document regarding the exercise and the sport participation in patients with the cardiovascular diseases. So regardless of this document that were mostly focused on prescribing sport and exercise, but mostly focused on competitive athletes, because at that time, one of the main topics of interest for the cardiology community was the sudden death in athletes. And so the document was mostly aimed to make a diagnosis and to prevent those events. Now, the scenario is quite different. Now, 2020, we are facing a pandemic of obesity, diabetic, metabolic disorder, not only in Europe, also even more in the United States. And so the awareness is that the cardiology societies and also scientific societies should prompt exercise and sport as a smart strategy to counteract the effect of this pandemic. Try to stop the pandemic or try to, let's say, improve the trends in diabetes, metabolic disorder, obesity, and so on and on. And obviously, sport is something that is appealing, is nice, is fun, people is pleased to do. So what we believe is that implementing as much as possible sport in patients with this disorder, including patients with the cardiovascular disease, is the best preventive strategy. Facing this issue, we now have a number of, let's say, issues related to the cardiovascular diseases and the impact of exercise and sport on natural course of the cardiovascular diseases. I have to say that for most of these diseases, there is relatively scarce scientific evidence in terms of trial, double-blind, aims for evaluating the effects of people with the disease doing sport versus people with the same disease not doing sport. Evidence, scientific evidence exists just for a few of these examples, for a few of these diseases. For instance, exists for certain cardiomyopathies and specifically for arrhythmogenic cardiomyopathy. However, the same evidence does not exist for all the diseases. For instance, in hypertrophic cardiomyopathy, now there are emerging evidence that hypertrophic cardiomyopathy should not be considered the cause of death in any case the patient is exposed to a sport participation. This was a concern that was actually based on the evidence of years ago, particularly on the evidence related to top or elite athletes, where a substantial number of these were found dead and found with this disease. So the scientific community was particularly afraid to allow sport participation in young individuals with hypertrophic cardiomyopathy. Now, after decades of small case series, observation, case report. There is still not a trial, but there are still emerging evidences that not the hypertrophic cardiomyopathy patients are exposed to the risk of death or worsening the clinical course of the disease just because they are exercising or they are participating in sport. Personally, we had some data that are published, and so now the guidelines, the today guidelines, actually accept this idea. Accept the idea that it can be possible, even for patients with hypertrophic cardiomyopathy, to undergo a risk stratification. And for those individuals that have mild phenotypic expression of the disease, mild or no left ventricular outflow obstruction, no relevant arrhythmias, very mild hypertrophy, we have, according to ESC, a score, and the score less than 4 indicates a very low risk. And if there are no symptoms and no family, no recurrence of sudden death among the relatives, so the overall scenario could be even better than the usual scenario, and those people can selectively, obviously, be allowed to participate in competitive sports, particularly if we are talking about adult individuals, people that maybe have been working, have been exercising for a long time, and the disease was discovered just by chance in the adult age. Here again, we published some data just recently. So in this sense, the guidelines are novel because they are receiving the novelty of the new studies. And in this sense, these guidelines, the European guidelines, are even much more liberal than before. For instance, sport participation is allowed in certain instances in patients with hypertrophic cardiomyopathy, but also in patients with dilated cardiomyopathy, in certain instances in patients with left ventricular non-compaction and so on. But the same attitude, the same, I would like to call liberal attitude in terms of, let's say, push the people towards a more active lifestyle. The same attitude can be seen when the guidelines approach patients with valvular diseases, where for patients with a relatively mild degree of valvular diseases, either aortic stenosis, aortic regurgitation, or even prosthesis, there is the advice for evaluation and follow-up, but allow and actually advise regular exercise and sports. Overall, we are talking about, in most cases, we are talking about a recreational sports activity, but the guidelines have also specific advice even for competitive sports. And so this is true for valvular diseases, cardiomyopathy, etc. Well, the main issue is coronary artery disease. People with maybe asymptomatic or mild symptomatic coronary artery disease. And I have to mention last year, 2019, European released the coronary syndrome, where there is a chapter also about the identification of people with the chronic coronary syndrome. They are still asymptomatic or with the mild symptomatic. The current guidelines of sports also are in line with these previous guidelines, and they recognize for detection of asymptomatic patients with coronary artery disease, they recognize the main role of the imaging technique, mostly coronary computed tomography, which is now widely available, not only in the United States, but also in Europe. And they can provide a really detailed anatomical, morphological assessment of the existence, degree, and type of the atherosclerotic lesions. However, morphology or anatomy of the coronary lesion is not all the story, because we need also some tests for functional evaluation. In other terms, we need to understand if these lesions are worse enough to cause ischemia during exercise, because this is the key point. Before advise people to exercise, we should know which is the potential risk of inducing ischemia. And exercise testing is still in Europe widely available. And so we rely on combination of imaging testing and functional testing to define what? To define the people with the chronic coronary syndrome, which are low risk and high risk. People with the low risk are people that have no evidence of ischemia during exercise, have no major arrhythmias during exercise, have normal left ventricular ejection fraction, and have overall the clinical picture, the clinical status very well controlled by the drugs. Those people are obviously allowed and even advised to engage in regular exercise. On the other hand, the people that are considered at high risk, either because of the severity or location or number of lesions, or because of the evidence of ischemia, or because there is an unstable clinical situation, they should undergo to medical and surgical treatment. Finally, one of the other major issues is people with the atrial fibrillation. These are the two pandemics, ischemic heart disease and atrial fibrillation. And mostly people are in the middle age. With regard to atrial fibrillation, the science, the cardiology paper says that there is a new shaped relationship, very high exercise training, particularly in master athletes, seems to be promoting favor for atrial fibrillation. So here the advice is for recreational, just low, medium intensity exercise training, but even sport participation is allowed. Particularly, I want to make just now a more detailed information about sport participation. When we say sport, we say everything. We have in the guidelines, we have a new classification of the sport. Why is new? Because the previous classification of the sport is, in our vision, is relatively too complex, too complicated. Class 1, Class 1B, Class 2, 3B. The usual clinical cardiology doesn't understand. We have, in our classification, we have 4 types of sport. Skill, such as golfing, power, such as weightlifting, mixed, such as football, basketball, and endurance, such as cycling, rowing, or marathon running. So this classification is much more intuitive. And in the classification, there is also a graduation of the intensity. In other terms, looking at the figures, the figure of the classification, the clinical cardiology, who does know very much about exercise, physiology, etc., however, can recognize the sport that have relatively low cardiovascular impact, medium cardiovascular impact, that can be advised to patients with conditions that are not perfect, from sports such as cycling, marathon running, triathlon, etc., that can be advised only in patients with cardiovascular disease that are very well controlled.